Just a few announcements. Sir has already made one. There's tea served in the side hall. Please participate in that. And this is Hall A.
Without any delay, I would like to call, with permission from the chair, the speakers for today's scientific session. Professor Jaswant Gosar from McGill University, Professor Shekhar Sheshadri from ICCAMH, Bangalore, India, and Jasmine Ma from, she's a psychiatrist working at Kanti Children's Hospital. I'd request you all to come up to the dais. We'll be presenting on Dreamer World Cultural Therapy Model, a school-based resiliency model. So I invite her to the podium and to give us
we started this project. So this is one of the people who was our kind of champion in the past, who had passed away, was the former Chancellor of the University of West Indies, the first Chancellor. He was born actually in rural Jamaica. Jamaica is really a post-slavery society. Slavery broke families. It broke the back of the patriarchal and the father involvement. So we have a huge problem with absence of fathers, multiple fathers in families, and matriarchally dominated single mother families often with many children with different fathers. And we have a situation where asylums and mental health is considered to be highly stigmatized. And nobody wants to see a psychiatrist, and certainly nobody wants to see a child psychiatrist, because seeing a child psychiatrist is tantamount to being involved with the asylum or being criticized. And it's the same in North America for us with the Caribbean families. We have the highest rate of admission to group homes in the Caribbean minority in a place like Montreal than we have for any other minority, because of a tremendous problem of attachment disorder due actually to intergenerational severe trauma of slavery. So the University of the West Indies wanted to do a community engagement project, and we started off by trying to work on a project called the Dreamer World Project. We started with almost no money, with 30 subjects and 30 controls, and then we moved into a scale-up with the Grand Challenges grant to 4 different ghetto communities with 4 different schools, 100 control cases and 100 subjects. And then we started a transition. Then we've moved into a transition to scale across the island of Jamaica. So we are now in 70 schools. But I want to talk to you about the beginning of this project, because no money is always part of the problem. After the Grand Challenges money ran out with the big project, we had to flounder with the government and beg the government that children are worth investing in. So everything I heard today is exactly what we say all the time to the government in Jamaica. So this was the problem then was that corporal punishment is very common in schools and is very common at home. And the domestic violence is very common. One of our big issues in designing this project was to engage teachers and was to use the school as a second chance. That is, that all children that we could get in grade school are the children that we were targeting. We were looking for the children who by grade 2 could not read or were so disruptive that you couldn't teach them. And the object of this intervention is to help children have agency and voice and be able to be socialized so that you could teach them, and to give them all the intervention in the school without putting any burden on the parents, because the parents would not come anywhere near any kind of services. So by the time the children get out of elementary school, they very rarely make it into high school. So that we would lose 40% of the population because we would be getting into the issue of early dropout, early pregnancy, etc., etc. This was a massive waste of a population, and then that goes on to conduct disorder, criminality, early pregnancy, and all kinds of... So the problem areas are different. They're almost the reverse of Nepal in a sense, because Nepal has a continuous culture of 4,000 or 5,000 years. It is a ritualized culture where there's internalization, I think, of many of the symptoms. There's almost the opposite in Jamaica, except that the internalizing symptoms are there as soon as anybody treats a conduct disorder. You know that all the PTSD and internalizing disorders are right underneath. So this is an example of the kind of thing that we would see at school. There's a huge amounts of regression, and the issue is nobody wants to treat these children, and they drop out, and so on. So it's girls and boys, as you can see. And so we chose a community in an area that had actually been taken over by a gangster, Dudas, if you ever have heard of him. He was a cocaine guy who was in, he lived in this area, and the people in the area were more loyal to the gangsters than they were to the police, because the gangsters provide a cash economy. Okay, and so there were many people murdered in this standoff between the gangs and the police. So we have therapeutic work engages the teachers in the school at the same time as the students. So what we were also doing is changing the attitude of the teachers, who instead of looking at these children as bad children, looking at these children, the belief system is that when a child is acting out, the best thing is to slap them, or to hit them, or to use the belt, or suspend them. And when Dr. Arun said the schools in Nepal will throw out the children that are very... This was working with this idea of being able to do everything in a circle and is centered as well as circle. This is an example of an activity that starts at the beginning of every day. We do a body exercise, which is somewhat like a mindfulness exercise, who's a consultant on this. And part of the project is then the children working in the summer, they are asked to dream of the world that they would like to live in. They have to create this world. They have to talk about what they don't like in their environment, anything we could get. Eventually, the community began to donate drums and other things, because Africa is very important, the drum, to tell us what kind of world they wanted. This is very hard. She says, I would like to call it tutu, and then later on she says, and I would like to become a doctor. The children actually wrote about their life, they wrote about plays, they learned to write their own poetry, presentation to their community. So at the beginning, the parents would come slowly. By the end of the 2 and begin, because they became the leaders in the school. Other children would say, how bad do I have to be to get into this group? Because they were receiving a therapeutic community. We were creating a different kind of mastery, of work with a musician. They wrote the music, they wrote the poems, they talked about their life, they talked about not wanting criminality.
The intervention, that the number of initiations made by the children increased, and that's persisted to 6 years. But we're not curing autism. What this shows is that after 6 years, those children in the intervention arm of the trial and difficulties than parents of children with other disabilities, but we have shown that we can help parents understand some of the social communication difficulties that young preschool and now primary school age children with autism have with both their verbal behaviour and also their non-verbal behaviour. We've shown that we can help children make those social initiations, and we've shown that at 6 years we are reducing for a significant proportion of these children the severity of their autism. Young children with developmental difficulties, and actually regularly developing children, how important these joint attention, shared play, and then symbolic play skills are. We have some early feasibility in low and middle income context, but we still need to think about, these are social communication interventions around one domain of the diagnostic criteria for autism. But we then need to think about how we combine that with helping families and individuals themselves manage their restrictive, repetitive behaviours, movements and routines, but also deal with the high rates of comorbidity that individuals across the autism spectrum also experience at different stages in their lifetime. Jackie will be talking about measures for us being able to identify anxiety, one very important comorbid mental health problem. But there is a whole range of functional difficulties. You know, if your family doesn't sleep because your child with autism has sleeping problems as well as anxiety and other maladaptive behaviours. But I just want to end by saying the great thing about working in this field is all individuals with autism have this pattern of skills as well as deficits. So it's important to get over the, oh no, what is the matter with my child, to thinking much more constructively about how to help social communication skills and then those skills to generalise. Thank you.
Thank you. Thank you.
In low and middle income countries, you use this task shifting methods so that it is feasible to, it's doable in low income countries and in rural areas. And I'm really eager to see more research on using these kind of skills in rural areas like Nepal. Thank you.
Thank you. Thank you.
We help with teachers. A time ago when teacher used to ask with me, how could we differentiate autism and intellectual disability? Because autism could comorbid with intellectual disability. Is there any assessment tools for the teachers in your practice in UK?
To generalise it rather more, the important issue is both to be able to develop a formulation about a child. So it isn't autism or intellectual disability. The likelihood is for many children those difficulties will co-occur, often combined with challenging behaviours, problems with attention and concentration and so on. One of the things I thought you might be going to ask when you're saying you're supporting teachers is teachers will often say, well, we can't manage this child in our class, and how are you expecting us to tailor the educational curriculum or provision for this one child? And I'm afraid I often say the techniques that we're recommending for the children with autism may well benefit a much broader group of children in the class. So slowing down, building on the child's skills and interests, engaging the child, and helping the peer group understand themselves how to engage with the child. It sounds fairly straightforward as I say this, but I think those techniques with the class teachers. In the UK we have a problem, and I'm framing it like that, with teachers who download some 12-item checklists and then say this child does or doesn't have autism. And I think we need to remember the diagnosis really does need to be multidisciplinary with information from school and the family.
Okay. Any more?
Regarding video feedback, how is feedback given to the parents through video to achieve synchronous parent-child interaction? Could you provide, explain us with an example? It will be more clear. Thank you.
Oh, that's such a wonderful question. In the parents, you can just use 2-minute clips, 5-minute clips. In our new intervention, parents do their own filming on their phone at home, and I don't know whether that's a possibility for some families. I'm astonished how many aha moments. So the parents go, huh, he is trying to tell me. And also if you help parents follow the child's lead, obviously they need to do other things, and so they can't be doing this all the time, but to help them think, what is he or she interested in? Could we turn that into play? So if the child is moving a cup or doing something in a repetitive way, how could the parent help the child develop that into a to and fro, rather than the parent necessarily saying, no, this is the way you clean your teeth. To build on everyday activities.
I'm representing as Autism Care Nepal. Like in 2007, they gave me the work to work with a CA member in Nepal, so that autism can be included as one of the disability. That's why in one of the 10 disability now, autism has been included as one of the disability in Nepal, and the government has allocated a little money, stipend, once the child is diagnosed. I think that money is also a little bit small facility for the children in Nepal. And I think Autism Care Nepal has started child-to-parent training in Autism Care Nepal. And like other program, they are going to start to sift the knowledge. We have huge amount of social worker in Nepal. There are a lot of social worker colleagues. I think they are planning to do the transferring the knowledge to how to handle the children at home and other. And I think the school level also they have already started in special education program, and lot of program are coming.
Okay. Okay, thank you very much. Thank you to the speakers. Stigma. So thank you very much for the speakers, because we can imagine the impact of autism on the individual, the family, and society. And your evidence, I think, is definitely good for our country like Nepal. Thank you very much. Now, I would like to request another chairperson to call upon another speaker, Dr. Kaspati.
Thank you, Dr. Sugar. I also would like to thank to the our presenters on these very important topics. I just have one, not the questions, but one request to both of you, since autism is everywhere and it's also becoming more in Nepal. So since you already started working in Southeast Asia, why don't also you think to expand the program in Nepal? Because we have now in China and adolescents like that, okay, with this, I would like to invite another speaker on the topic, which is also very, very interesting topic.
Teachers and seniors also. It's good experiences presenting in front of them. Tool development, can we develop tool for the children which can be used locally and which has some meanings associated with our day-to-day language? It has always been a curiosity, and the project I'm sharing is regarding development of such tool. And it's an integral part of my PhD project, as just earlier mentioned. I owe my gratitude to my supervisors and my mentors. So on their behalf too, I'm just presenting this. Childhood problem exists, and we all know, and prevalence, if we calculate, it's roughly similar all over the world, and even with Nepalese data, it's similar. But the problem is, now if we have problem, then how do we identify? And how do we manage, given our condition where we have very less professionals specially trained for that, where we have tried to fulfill that gap with task sifting, as we discussed earlier. So how do we come up with simple measures? We do have some measures available for childhood emotional behavior problem, but still many of them, they lack local norms, and especially cultural adaptation issues, and the affordability issue. For example, if we want to use this tool in our local level, of course we can't pay huge sum of money to international authors or public producers of the tool. And another one is regarding Nepalese idiom of distress. When we translate, we have some issues like, even though we go with rigorous cultural translation procedures, but still we do have issues when we translate. So we thought, why don't we also try to work something on it? Just like in 50 years ago, Cattell said,
there is always a demand for a test which is brief enough for a large number of busy people, and a test which is intelligible enough or simple enough for a person of lowest educational level to follow, and the test mechanical enough or for relatively untrained assistants to administer. I think it's very relevant in our context too. That was cited in Burma's work in 1978. And so we had two objectives in our mind. First, what sort of problems, what type of problems exist or are being reported in Nepalese scenario? And can we utilize that knowledge to form a valid tool or measure? But we had so many questions to ask. How do we define emotional and behavioral problems in children? And when do we say that there is a problem in children? And who says that there is a problem? An adolescent who might be saying that, see, I'm sad and I need some help, but parents might be thinking that my child is very, let's say, they doesn't have problem. He has very good discipline. He doesn't talk, stays quietly. But so a problem for one person might be no problem for other. So who says that there is a problem, and what are the consequences of the problem, so that motivates us to seek help? Seeking help doesn't only mean mental health professionals. Seeking help from teachers, seeking help from other people in the community. And there are a few other questions to ask, like, are there cultural differences or similarities of childhood problems all over the world? And of course, though there are many similarities, because we all are humans anyway, we have universal values and norms, but still there are some different manifestations due to our difference in culture, and we try to focus on that. Please be seated. We will just try to wait for a while. Some questions we ask about ourselves while we are to develop certain tools. The second question is about whether we want to make tools from top-down approach or bottom-up approach. Especially top-down approach. In top-down approach, there are certain group of experts. They will try to form certain criteria according to their expertise, and they will try to utilize that in the field. So for example, the diagnostic system, existing diagnostic system, they are more about top-down approach, diagnostically based assessment. And there is another approach that's empirically based assessment, where data is generated from community, and from that data, utilizing various analytical strategies, we come up with certain theories, we come up with certain criteria on the basis of which we try to define emotional behavioral problems. So, of course, we really wanted to follow empirically based assessment, and another question was, what type of problems do exist? Do they exist in categories? Or problems exist in dimension? For instance, does a child have anxiety disorder? Yes or no? So are we trying to form categories, or we are interested to form certain continuum? Where does the child's anxiety fall on a continuum? So do we want to assess dimensionally or categorically? So this is another question. Of course, we really wanted to focus on dimensional approach. And there are so many other questions to ask before really trying to work on tool, like whether we want to include strength-based approaches in our tool development. For example, are we just measuring disabilities? Are we just measuring incapacities? Are we just measuring problems? Or do we also have responsibility of including strength assessment? So that's another school of thought. For example, World Health Organization's document like International Classification of Functioning and Disabilities, that's one example of strength-based approach. But unfortunately, we couldn't integrate this approach in our study, but we plan to do that in the future. And there are other approaches like person-centered oriented approaches, those who are interested in cluster analytical method rather than factor analytical method. I think they are more interested in person-oriented approach, so I won't go in detail right now. So this is the model finally we came up. So we really wanted to know what type of problems or help children need, rather than problem, I would say what type of help children need. And then after that would be manifested in some sort of internalizing or externalizing behavior, and that would be reflected in guardians' report, whether free listening interview or whether it's in a structured questionnaire. And this will represent whether child needs help or not. So this was the model, and of course we try to focus on parental report. So, so we had 3 stages before we moved on. So the first one is about if we want to develop a questionnaire, then what type of problems do exist and how do we get the pool of items? So what are our raw materials? And the second stage is more about if we generate items, if we have criteria, then does it really fit with existing system of measurement, existing criteria? What about the contents? So it's more about content validity issue or content adequacy issue and some pilot tests. And the third stage was more about field testing, and it was more concerned about psychometric property of the questionnaire developed. So what sort of problems are reported? Does the tool cover? And these are some questions we were motivated for. And this was the nature of number of sample. For the first stage, since it was more qualitative, sample size depended on the qualitative nature of analysis, for example, data saturation. And second and third stage, it was more based on the type of analysis we intended to do. For example, factor analysis. 508 parental reports of the children who were referred at Trinity University Teaching Hospital, Kansi Children's Hospital, and some other centers in Kathmandu, and a medical college in Nepalganj. And for a community sample, that was a government and private school in Kathmandu, they were selected. And regarding the findings, the first stage, can we be able to group these 89 items into certain groups? I mean, statistically, can we form certain syndromes so that these syndromes could be utilized as skillful questionnaires? For example,
when he referred to the initiative that is going to be started here as part of the UNICEF supported activity. In the last 4 years, the slide may not be very clear, we've covered over 230 childcare institutions. We have covered about 6,000 children. The number of service providers who've been trained is over 2,000, and we have managed to extend this program beyond the state where Bangalore is located to other states in India, particularly Andhra Pradesh, Gujarat, where all districts have reached. And we have also extended the learning from this project to other countries, particularly to Sri Lanka, Cambodia, Bhutan, Afghanistan, Bangladesh, and now increasingly to Nepal. We've also done almost 900 public awareness programs as part of. I wanted to state that This was originally conceived as a proposal that we had given to the central government to set up our public health and community work in child mental health services, which was budgeted for Indian rupees 5 crores. The budget on the project was not approved. We therefore put the project to the state government women and child department, who gave us a princely sum of 60 lakhs for a 4-year project, which has been run by 1.5 people. Just 1 permanent staff and 1 person as resource. This entire thing has been done by just 1.5 persons because of the manner in which the project was planned and executed. So what do we know so far? What are our experiences and insights from this project? As far as the primary healthcare centers is concerned, there's something known as the link workers, and the community mobilization by them is exceedingly variable and often is very poor. Despite the fact that they attend orientation workshops, they are unable to transfer house-to-house messages. There are, of course, enormous systemic issues in the primary healthcare system. They are overburdened by the many vertical health programs and the national health programs that the center has. The health system in India is now transitioning to a new system under the National Urban Health Mission and the National Rural Health Mission. And it has now become incentive-based, and this is going to be a huge problem as far as mental health is concerned. The medical officers are frequently absent or unavailable, and there's a perception that the expert who runs the project will actually come and provide the services. So can we really integrate child mental health into primary healthcare services? There is scope and potential, but is there interest and will? And it's only strong leadership that can really make it happen. I state this particularly in Nepal because after federalization has taken place and the provinces have been defined, particularly the project that Arun has conceptualized, would there be a provincial mental health program into which the UNICEF pilot can plug in to really ensure that the health system is receptive to the whole idea of decentralized child mental health care? In schools, we found that anxiety was a common emotional problem. ADHD alone accounted for half the behavior disorders. And just as Justin pointed out, in Jamaica, anger and aggression issues are also frequently occurring conduct symptoms. Here is the most important thing. We feel that teachers cannot really be trained to become good counselors because the nature of adult-child relationships are such. However much you train a teacher, there is always a tendency to use the dynamics of that relationship to respond to a child, however good your intention may be. So the approach always is, you have a problem? Come, I will counsel you. The majority of children who reported anxiety said that they were greatly benefited by our training of the teachers on what we call as a first level response, which is a validation of the child's anxiety or a validation of the child's anger, a sensitive understanding of the context and the cause of that anxiety or anger, and a commitment to assist the child further. It is just 3 simple responses. I see that you're anxious. Shall we try and understand what makes you anxious? Let me also think and ruminate on what you have told me so that I can get back to you with more suggestions. And children felt greatly assisted by the teacher's interest and motivation to support and assist the child. So it is not that anything deep, dynamic, or complex has to be done in terms of providing assistance to these children. We also started an innovative experiment in these schools to meet the needs of children with learning difficulties with a simple model for remedial education. Unfortunately, the field of educational psychology and remedial education with trained remedial teachers is something that is found more in private schools in urban locations. Government schools and schools in just outside the city as well in rural areas is unheard of. So simple orientation of teachers on children learning problems and on-the-job classroom training of teachers in the use of some very basic remedial techniques as applicable to low-resource settings really went a long way to help children with learning problems. There is an issue with the Anganwadi systems. Anganwadi teachers feel that early child health is only about adequate nutrition. They find it difficult to perceive that the role of early stimulation and preschool education plays a huge role in child development and health. They also find it difficult to identify children with mild disability. Children with severe or profound disability may never reach a system. But a child with mild disability who is otherwise conscious and receptive is often mistaken to be either unmotivated or lazy because the Anganwadi teachers are not trained enough to recognize mild disability. Along with UNICEF in India, we have also initiated a new program as an ancillary offshoot of this project to look at child protection in the context of children who are preschoolers. Many of these children come from situations and families where there is parental discord, there is the theme of alcoholism, there is exposure to domestic violence and physical abuse. And often this is not a systematic source of receptivity and alertness on the part of the Anganwadi teachers to pay attention to these children. So these are part of the issues that we are upscaling.
At this fantastic event, so thank you for giving me the opportunity to talk to you today. The talk that I'm going to give today really kind of blends themes from both of the previous talks. So I'm going to be talking about autism, but I'm also going to be talking about the development of an assessment tool for anxiety difficulties amongst those on the autism spectrum. Sorry. So we know that anxiety is a very common experience for individuals on the autism spectrum, and that anxiety often develops in early childhood and persists through into adulthood. So this is not something that kind of dissipates with development. There, as I will go on to talk about it, there are some difficulties with the assessment of anxiety amongst those on the autism spectrum. Sorry. Into adulthood, and actually maybe one of the precursors of the very high rates of suicide that we see amongst autistic adults. So some other work that I'm involved in, for example, looking at suicidality in autism, indicates worryingly to us that autistic adults are around 9 times more likely to die by suicide than members of the general population. And of course it's really important for us to try and understand the mental health experiences of those on the spectrum in order to be able to support them and support those who are supporting them. The rates of anxiety are very variable if you look at the literature on anxiety in autism. A recent meta-analysis from colleagues in the Netherlands suggests that around about 50% of children with a diagnosis of autism will experience anxiety to the degree that it has a significant impact on their daily lives. So this is a much higher rate than we would see in neurotypical children, or indeed in children with other neurodevelopmental disorders. But if you look at the published research literature, the rates vary quite markedly between papers, with some papers reporting anxiety rates of around about 22%, up to around about 84%. And of course, some of that is going to be explained by the different inclusion-exclusion criteria that have been used for those individual studies. But one of the things that's concerned us, working with families with a child on the autism spectrum, is that perhaps one way in which we may be able to explain this variability in the rates of anxiety and autism in the literature is by exploring the measurement properties of the tools that have been used in these individual studies. And it doesn't take long to realise that when we go to this research literature, the tools exclusively that have been used to assess anxiety to date in children with a diagnosis of autism are all tools that have been developed for and validated with neurotypical children. And they haven't been validated or even developed for children on the autism spectrum. So perhaps what we really need to be doing is thinking carefully about how we assess and identify anxiety for those on the spectrum. And of course this has huge implications both for research but also for our clinical practice too, so that we can identify children who need support. In recent years, there's been some work by colleagues in the States and also from our group in the Wigham and McConaughey paper there, looking at the use of these tools developed with neurotypical children to assess anxiety in those on the autism spectrum. So they have looked at the evidence for a number of very widely used tools. And essentially the conclusion of both of these reviews, although they were done very separately, is that if we take an off-the-shelf anxiety measurement tool and we use it with children with autism to try and identify whether or not they're experiencing anxiety, it won't be a disaster. The tool will be okay, but it may miss important information that we as clinicians and researchers working with people on the spectrum need to know about the way that anxiety presents in autistic people and how we understand and best support that individual. So both of these reviews urge caution in the use and interpretation of these standardized assessment tools. So why might these very well validated and robust tools not work so well for people on the spectrum? Well, there are multiple suggestions as to why they might not work brilliantly, and these are not mutually exclusive, of course. We know that children with autism develop somewhat differently to neurotypical children. And so in that sense, it's logical to think that mental health may develop differently for children with autism. So age-related norms may need to be considered differently when working with kids on the spectrum. We also know from our clinical work and other research that we've done that there may be differential routes to and presentations of anxiety in individuals on the spectrum. And I'll talk a bit more about that in a moment. But of course, if there are different triggers to anxiety for children with autism, and also when they're experiencing anxiety, it may look a bit different to how it looks for neurotypical children, then by definition there will be gaps in the measures that we use if that measure has been developed for a neurotypical child. In addition, we know from our work that that what autism is bringing to the situation and what anxiety is bringing to the situation may interact in quite an interesting way to produce a particular profile of anxiety symptomatology that may not be picked up by these standardized tools. So, for example, we've done extensive work looking at the relationship between repetitive behaviours and anxiety in autistic children. We know autistic children are repetitive and can be quite rigid behaviourally, as Ellie talked about earlier. But what we also know is that when autistic children are feeling anxious, they become more repetitive and they become more rigid in their thinking because of the interaction between their autism characteristics and their mental health characteristics. And of course, asking about an increase in repetitive behaviours is not something a standardised tool is going to ask about. So we're going to miss some of that important information.
You know, when you speak about privacy, why do windows have curtains, or why does the house have a roof, or why do we bathe? Why when we bathe do we even close the door? So these are very simple methodologies, and like I said, all this material is ready and it's ready for use, and it's been written in manualized form so that you can implement it directly in the field. So all this will be out on the website as soon as it's ready, and I'd be happy to share it with all of you.
Dr. Suresh Thapa.
Yeah, my name is Suresh Thapa. I'm from University of Oslo. First of all, I would like to thank all the presenters, Professor Sekhar and Professor Guster, and then Dr. Jasmine for their excellent presentations. And then you two have already got enough questions, so I will move to Dr. Jasmine. It won't be fair if nobody asks, right? So, first of all, I would like to congratulate you because you are the first one who have successfully completed an epidemiology study among children of Nepal, which has been lacking for many, many years. And then earlier we heard that even NSRC is going to has already piloted its pilot study among adults and the children, which is very good. I think this is going to be a landmark for building up the psychiatric service in Nepal. And my question is something to do with the gender. We have already discussed about the gender. You showed that the boys had more problems in different dimensions compared to the girls. Do you have any explanation for that? And the other thing is that you use child behavior checklist, right? I'm an adult psychiatrist, so I'm very ignorant about the child psychiatry, but still, I was wondering, could you have used some other diagnostic instrument? Because the guy who was talking about the pilot study mentioned that he is going to use, or he has already used, mini child version or something like that. So I was just curious on why you choose that particular instrument but not a diagnostic instrument. Thank you.
Thank you very much for the question. And regarding why I chose the child behavior checklist, we had actually options between we were planning to use either the strength and difficulty questionnaire or child behavior checklist, and we had even conducted a focus group discussion among psychiatrists and psychologists and also among the teachers, and we gave out the forms, both the strength and difficulties questionnaire, which is a short forms of emotion, have a short questionnaires of emotional and behavioral questionnaires as well. But when we had a focus group discussions, all the participants, the teachers and parents and even the psychologists, they believe that though the questions were rather short, there are few numbers of questions, but not much elaborated as in child behavior checklist. So based on those focus group discussions, we decided that this is a screening tool. So we wanted to first screen the problems. So we decided on using the child behavior checklist. And regarding the other questions like why boys were higher than girls, only in one behavioral scale, that was in anxious depressed, there was girls were slightly higher than the boys, and this is just a report from the parents. So on parents' perception, maybe in our culture we look too much into the boys because we prefer boys. Not we, it's a general cultural thing. So maybe they think too much about how they behave, how they act, how they perceive things. All these emotional and behavioral problems that came out, in which the boys came out higher, is given by the parents' report. And we still have to look into the teacher's report as well. So based on those findings, then we'll be able to say which one is higher. It's just a glimpse of the results. Thank you.
I'm Hosna Shrestha. I'm working as a clinical psychologist. So I would like to know something from Dr. Jaswant, and also would love to hear from Dr. Sekhar as well. So while working with children, especially in school setting, the two other important factors that are included are school system itself and the parents. So can you please share your experiences, like how you coordinated the school system and the parents while working with the children? Because currently I'm facing lots of challenges like working with the school system.
The school that we chose was with Mrs. Crooksmith, who is our champion. And we consider that in every school, if we're going to engage with them at all, and I don't know if it was the same process for some of your studies, but if you don't have a champion in the community or in the school, it is very, very difficult to change anything with the teachers underneath that principal. I remember that one of the first principals who wanted us to do a study, a vice principal called us and said, the principal of the school is an alcoholic. He walks around the school with a belt, and we would like you to do the Dream World study in that school. Well, let me tell you, we didn't choose that school. Okay, we would say, we think, and all the children were also carrying weapons. So we suggested a metal detector and getting the principal fired. But you really have to think that we're dealing with ghetto situations. It's very important that the school is an environment and it's a community by itself. So the parents collectively are very highly stigmatized about mental health. But all parents universally want their children to go to school. All parents want their children to learn. So that's the engagement. If I offer you no burden as a parent except filling out these questionnaires, and you can decide for yourself if the child is progressing. We got to buy in very gradually. Over 2.5 years, we saw a real change in the parents, and we didn't expect that. We didn't actually even expect the reaction of the teachers, who argued with us terribly about using the belt, because they really believe that if a child is acting out, the only thing that that child will understand is force and the belt, because that's how they had been brought up. So we had a lot of discussions with these teachers about attachment disorder, about attachment process, about their own childhoods. We saw teachers even dissociating in some of these workshops we would have for a week. So I think this is a very interesting question about action research, what the community teaches you. And I'm sure you would have something to say about that.
No, I just wanted to say that the technique that I use is precisely the same technique that I use to work with children with conduct disorder. Context establishment, consensus building, motivation enhancement, and insight facilitation. With a child with conduct disorder, is there a context? You ask the child, what brings you here? And the child starts and says, I have no idea, ask my parents. Or the child says, I'm brought here because of my anger. Consensus building, I know I get angry, but it's not as big as my parents make it out to be. Motivation enhancement, yes, it's a problem, and it's a big problem, but I don't want to do anything about it. And insight facilitation is, so when we approach a school to actually run a program, one of the things that you use to gain an entry point often is the use of stories. And one of the stories I commonly use is, so there was this 37-year-old guy who came back to school and met his teacher who was on the verge of retirement, and asked the teacher, do you remember me? And she looked at him and said, no, I don't. Because obviously 20 years after you left school, your face changes and so on, and you grow a beard and you look very different. He said, but I have not forgotten you. I don't know whether you recall, but I come from a very troubled family, and truth be told, I have never reconciled with my family. I don't know what it is that you noticed on my face one day. You called me aside, and I remember you did not embarrass me by calling me in front of my classmates. You called me very quietly when I was going out and told me, child, you appear to be a little quiet and out of sorts today. Is anything the matter? And I told you about the terrible things that happened at home. It's not that you did anything in particular, you just said it must have been so difficult to keep these feelings inside of you. If you'd like to talk about it any time, please don't hesitate to come to me, and if there's anything I can possibly do, I would be happy to do so. And I have never ever forgotten that act of kindness. So for a teacher to understand that you